My name is Sonia Gupta. I'm the Senior Medical Director of RAD AI, and I'm a radiologist as well, with a passion for artificial intelligence. And I'm so excited that you all have taken the time to join us today on this Thursday afternoon or earlier in the day, depending on your time zone, for our webinar on AI education. And I'm so excited for our panel. We have Dr. Chang, who is just speaking. He is actually the founder of AI Med and the Chief Intelligence and Innovation Officer of the Children's Hospital of Orange County. Thank you, Dr. Chang, for being here. We have Dr. Jessica Stewart. She's an assistant professor of radiology at UCLA, and she's also the vice chair of the GERB AI Advisory Board. And shortly we'll have Dr. Ari Goldberg joining us as well, who's the director of thoracic and abdominal imaging at Loyola. So thank you all, and thank you to everyone who is signed in right now. We'll be taking questions at the end, but we'll just be starting off our discussion to first talk about, there's a lot of enthusiasm, obviously, for artificial intelligence in the healthcare space. And, more and more it's a topic of conversation, no matter what medical specialty you're in, for medical students who are considering what they're going to be doing, for residents who are going out into practice after fellowship. So I want to just start with Dr. Chang. How are you learning about AI, or have you learned about AI? And I know that's kind of a trick question for you because you are our resident AI expert and you've written a textbook and teach a course. So maybe if you could just talk about your journey, how it started and how you came to become an expert.
Well, I was always that nerdy kid that loved math and taught statistics. And as the two of you can relate, statistics is usually something that in any kind of course, no one wants to really teach it. No one likes it. I was always the one to pick that up. And I think it was when I was doing my cardiology fellowship, I was working at the time at Children's Hospital of Philadelphia with a very famous heart surgeon named Bill Norwood. And he was a heart surgeon, but he was also a PhD in complex math and physics. And he was the one to convince me to really make good use of my math skills, and got me into all sorts of super nerdy topics like complexity theory and chaos theory. And we really worked together very nicely in that area. And then I think I told you the story when Watson beat the human contestants on Jeopardy was the night that I had this epiphany that I think AI is here to stay this time. So that was the night that I downloaded the application for the Stanford program, and to my pleasant surprise, 2 days later, they called me and said, you're in. And then they said, how are your programming skills? And I said, well, I like Java. I work with Java. And they said, you won't be needing that because it's a totally different world here. So even though I always say AI in medicine is not about the programming, it's about understanding the concept and how to apply it. Stanford was really mostly a lot of programming in R and Python and MATLAB to really understand the basics of AI in medicine. But I'm really glad that I actually did all that, because it really gives you a very good understanding of what AI in medicine is about.
Yeah, I think, actually, I'm going to jump into another question. Do you think that we should all learn, Python and start trying to code? Because I know that's a question that comes up a lot with clinicians who, some of them are mid-career, like far along, right? We're just specialists in our area, and then you're trying to throw in something brand new like that, essentially learning another language.
So I draw this analogy, Sonia, that, I'm a violin player, and I think clinicians are in this Baroque orchestra of string players, and now we're advancing into the Romantic period where you have woodwinds and horns and even singers. And I always say that, you should not necessarily abandon your string section and go learn play the trumpet just because there's a trumpet player now, because that trumpet player took a lot of time to get to be as good as he or she is at this point. And you're better off just staying in the string section, learn to play and learn the dynamics of having new instruments in your orchestra, which is more important than to kind of go drop the violin and go play the trumpet, because it's going to take you a while. it's going to take you 3,000 to 5,000 hours to get to the point anywhere close to what they do.
Yeah, no, that's a really great analogy. Dr. Goldberg, hey, how are you? It's great to see you. We were just talking about Dr. Chang's journey, and learning about AI and whether, we think we should all learn how to code, because that's a frequent question that comes up with clinicians. To both you and Dr. Stewart, what are your thoughts on that? Because Dr. Chang brings up a great point. I mean, you are very subspecialized in something already, and maybe you're the star of the string section.
Yeah, so I mean, I think I completely agree with that analogy. We all have our strengths that we've worked so hard to develop over time, and I think that's what we can really bring, to the expertise of others who are maybe more focused on the coding and everything like that. Again, it would take us thousands of hours to get where they are, and there's no need to reinvent the wheel. We can work as teams with these people, and we can bring the clinical perspective, which is so important and which they're often missing on that side.
Yeah, what about you, Dr. Goldberg? What do you think?
I agree in general, but I will say that, I happen to have like a technical background. So I did a lot of coding, and I definitely have found it, I would say it's not necessary, I agree, but I've definitely found more enjoyable doing research and trying to work on new projects and products and stuff with that having a coding background, because I do think there are times when I can I can come up with ideas, but I can also self-regulate those quickly. I've been saying, well, that's realistic with the current state of coding and not, those kinds of things. So not necessary, but I do think it does make it the whole process kind of more enjoyable.
I was just going to say, probably for 5, 10, 15% of the clinicians that you really want to go that route. But every time we try to teach a workshop or something, an hour later, the eyes are glassed over. So it is not easy. But having said that, what's really nice is with UpperML and some of the tools now available, like Orange, you may not have to code at that level and still get the data science enjoyment out of the projects. Or you can do what I do, which is, really read, a lot about what's new in development. And maybe your data scientist colleagues haven't had a chance to really, read, in terms of what's on the bleeding edge, cutting edge. And you can also contribute that way, just knowing the development of the really, really new AI tools that maybe not everyone's aware of.
Yeah, definitely. And, we're all in education. How are you engaging residents and fellows who are interested in AI? I mean, and medical students as well, because we're attendings, right? So they're thinking that we're already kind of knowing what we're doing. So, that's definitely something that comes up. Those who are asking for mentorship in that space and they want to do research or work on projects with you. How do you kind of go about that? Dr. Stewart?
Yeah, so the way that I've mainly involved residents and trainees and medical students so far is essentially I partnered up with a company that was interested in having some folks work on a project with them for a publication, and I had medical students that were wanting to work on this and were interested about learning. So we kind of all signed on to help them, work with their data set and see, how we could, kind of present this for a publication. And in the process, we were learning about the algorithm. So really just kind of letting us all, together kind of jump in on a project where we can and kind of collaborate with industry is how I've been doing it. And I think they found it useful in terms of just learning about the algorithms, kind of learning by doing in that way.
Yeah, that's an interesting point because, from the industry perspective, they are thinking about marketing, project strategy, sales, business development, right? And I think the academic component sometimes comes later, and that later on they're interested in perhaps getting a chief medical officer, perhaps getting some research projects under their belt, but they sometimes don't know where to start. And I think that's really great because you see a lot of companies now partnering with academic institutions to kind of launch these centers for education and publication and research. Dr. Goldberg, what's been your experience with that?
Yeah, actually, it's a very good point. I've had a varied experience. There's been some partners that have really been just of the mindset of give me your data, and we've actually kind of rejected those partnerships because they really don't do much for us aside, you get your name on a paper or something like that, but So we've really been more adamant about demanding access to prototypes that are being developed. And then with those prototypes, we can do some of our own studies. Maybe the companies aren't interested in those studies because it doesn't advance their particular product interest, but that's okay. It still creates research, interest and opportunities for us. And then, in terms of involving medical students and residents, it's really, I've treated it the same way. I don't know if I'm right in doing it, but I've treated it the same way as any other kind of research opportunity and field. When those who are interested, and I've said, great, we have a bunch of projects going, and here's the different ways in which you could participate.
And Dr. Chang, I think you're at the helm of quite a movement of clinicians who are interested in artificial intelligence and industry leaders. What's been your experience kind of bringing that ecosystem together?
Yeah, so I'm going to draw another analogy. Pretend you just got named as the US ambassador to France and you don't speak a word of French. How likely are you going to make huge impact in France? So I think that you don't have to, read 18th century French literature, but it would be nice if you're at least conversational. So I try to design projects and programs and workshops where someone can come in within a day or two, get a pretty good handle on sort of the basic terminology and what they mean, and so make it a lot less sort of mysterious, and try to bring a lot of clinical relevance. So when I go over the vocabulary very quickly and the concepts, and then try to bring in clinical cases and studies, that's when they get excited, like, okay, I get what CNNs do now, and why that's important. So, and try to do that as painlessly as possible without going over, the 18 different CNNs, which, again, the eyes just glass over when we do that. So make it fun. Also, the bottom line is you want to make it fun for especially trainees, because this is going to be an even bigger part of their career than our career, or at least my career. So it's really important that they think this is fun, and this is going to add a lot of extra sort of dimension to medicine.
What was your experience, writing a book that is making AI more accessible for clinicians, making it digestible, like you said?
Well, the book was a labor of love. I basically took 4 years of my class notes at Stanford and kind of distilled it into, I think, more understandable terms and way to explain things. Like I'm talking to a clinician friend, but at the same time, I wrote part of the book for also the data scientists who, just like us, getting confused about AI terminology. They oftentimes get very confused with how medicine is practiced and what the terms are. So I kind of wrote it for them as well. So it's kind of fun to write it with a dual perspective that I was privileged to have, and kind of split down the middle and explain things so that the data scientists also get something out of it. It was not written just for the clinician. It was also written for the data scientists in healthcare.
And I think, now something that a lot of people are talking about are certifications, getting board certified, some way to learn about AI and to be able to have, credential, because you're in a position where you might be teaching at an academic center. So I don't know what you all think about that, or where we might be with that.
Yeah, well, thanks to Gorbet and people at Gorbet and a couple of people in radiology, like Dr. Boyko, we decided that there was a need that wasn't being filled, and there's only so much you can get from a virtual programs or a bunch of YouTube videos. So we wanted to put something together that was fun for the attendee and live. I felt like, just like class, being live makes a big difference than watching videos. Just much more engaging, much more interactive. So we put together a 2-day course. It's been pretty popular and pretty well attended. And as you know, Sonia, the assessments have been pretty good. I think we wanted to do a review course, not like any other, in terms of just sitting back and taking hundreds, if not thousands, of PowerPoint slides. We wanted to be different in terms of having the faculty all react and discuss a slide, which was kind of fun for faculty too, because we blend the faculty, so it's different every time. So in essence, you learn from everybody on every single slide, and that's been, I think, a successful format based on our attendees. So, and then they get an educational certificate, but the original vision still includes trying to get a fellowship training as well as board certification under this board in the next year or two.
That's awesome. Yeah, I mean, it's been exciting to see the interest because I think there's also a lot of people that are just completely self-taught and they're trying to figure out, what resources they should be focusing on. Dr. Stewart, what kind of resources have you been looking into? Because I know you're working with medical students and trying to, but you guys are publishing papers on this in the space.
Yeah, so I mean, really just reading, articles where I can. There's a journal of intelligence and medicine that was where we were submitting. So reading some articles from there. There's some resources online, like on the AI Med website, for example, obviously. But also, as far as just learning more about it, I've recently joined a working group at my home institution that was just started, where it's a small working group of attendings that are going to be evaluating new technologies as kind of they get presented to us at UCLA. So just kind of starting to attend meetings with these different companies and learning about each of their technologies, kind of very practically about how we could apply it clinically has been really useful. So just kind of jumping in and kind of learning how to evaluate these new technologies.
That sounds great. And it's great that your home institution is taking that initiative, because that's an important piece, I think, for those who are in the position of making recommendations for potentially purchasing or partnering with a company that is involved in the healthcare space, and trying to improve patient care using artificial intelligence. Dr. Goldberg, you mentioned you already had a lot of technical background and know how to code. So has your journey kind of shifted a little bit now that more people around you are talking about AI?
That's a good question. I wouldn't even really have a great frame of reference from beforehand, because even though I had a tech, but I certainly wasn't applying it to AI coding. I would say that I feel fortunate that I can sort of sometimes be the go-between, in terms of some of the technology and some of the clinicians and residents asking questions about it. But I would say that, and I would actually say one thing, Dr. made an interesting point about we have actually a multi-hospital system, and we have that same board, right? That same kind of board of evaluating all AI products, which is good in one sense, but can be bad in the other, in the sense that it can be a barrier to kind of entrance, right? Because there's obviously this sort of bottleneck. So that's definitely double-edged.
Yeah, I mean, I think the pace of making a decision with a committee can sometimes be more deliberate, and yeah, definitely could be a barrier, but then might also be necessary because, like you mentioned earlier, there are companies that show up asking just for your data, and it's your patient's data. And that's not really, I don't know if the best way to start a partnership or, make a request of anyone. So perhaps it's really necessary. How are you all approaching, or is there a committee for ethics of AI, for example, at your institutions as you make these decisions about patient care as it relates to AI?
I think, yeah, we often talk about ethics, of course, and also obviously health inequities. That's actually looming really large. Ironically, I'm in the throes of finishing my application for an NIH grant to look at inequities and using AI to leverage as a resource to decrease that. But so I think it is becoming a bigger and bigger issue, if not very big already. So I do think we need to pay attention to that, but I often ask the counter question, which is it ethical not to deploy AI tools are really, pretty mature? And I think by the end of the decade, we'll be asking the counter question just as often as we ask, is it ethical to use AI? And I remember about 10 years ago when I talk about AI in medicine, there used to be a lot of emotional pushback from clinicians about, is it ethical to use AI? Are you trying to replace us? Questions like that, which I no longer hear. It's more about how do we best accommodate this, resource, and how can we be responsible for the ethics of using it? But let's be fair, and let's also ask the question, is it ethical not to use it? I think by the end of the decade, we'll see cases in which a clinician may be in some medical legal issue by not deploying a tool that's readily available. I predicted that 10 years ago that it might happen within a decade, so we'll see.
Yeah, I mean, I think that's an interesting point. Especially in radiology, we have images that are saved to our system. And a question that has come up in some of these meetings is, if the AI makes a decision and the radiologist disagrees with it, is that recorded? And is there a picture of it in the system that you could look at later and then come back and would there be a legal issue potentially? And I don't think we really are at a place where we have an answer to that question right now, or any precedent for it. But I guess Dr. Stewart's an interventional radiologist, so she's doing procedures. So I'm not sure from her standpoint what you would think about something like that.
Yeah, I mean, I was looking at a technology recently about, like PE detection and kind of activating a PE response team and things like that. So, I mean, I think it could maybe come into play more with like identifying who would benefit from certain interventions and things like that. And maybe some like supplemental tools to help aid us during the procedure, like in getting to a specific vessel that we might have seen bleeding on a CT or whatever. But luckily in procedures, everything kind of happens in real time, and there isn't as much of a paper trail as there is for you guys. So,
Yeah, Dr. Goldberg, you're an abdominal imager and thoracic imager. What are your thoughts on that?
Well, yeah, I mean, like you said, there's so many different possible scenarios and different ways technology can be fitted that it's really hard to talk about in generalities, I think, when it comes to the ethics and the medical legal ramifications. I think those are going to be, as Dr. Chang said, probably over the next few years, we'll probably see a lot of that being fleshed out. Right now, there's a lot of caution on the part of everybody, right? Even the companies, right? What kind of FDA clearance they're going to get for what kind of. So I think right now everybody's treading appropriately cautiously, and I think we'll have a little more clarity over the next few years.
Yeah, I think there's a lot of unknown right now. And speaking of that, what I'd like to ask all of you what advice you would give to those who are interested in AI, but they have no idea where to start and they're just completely overwhelmed with resources because there are so many out there. What are your thoughts on that, Dr. Stewart?
I would just say, just go ahead and jump right in wherever you can. So if there's a working group in your department, see if you can join it, or if there's not, see if you can become involved in evaluating new technologies that might be getting brought forward, and kind of, looking into them by yourself and just kind of figuring that out, doing some reading, and using the resources that there are available on the internet and courses. There's nothing to really be scared of here, and we're all learning this on the fly mostly, unless we've got obviously a data and programming background. But there's nothing to be afraid of, and you have a lot to bring as far as clinical expertise. So just go ahead and dive in where you can, whatever projects fall into your lap.
Yeah, I mean, that's great advice. If there isn't a work group or working group or committee, you could be the one to start it or suggest starting it at your institution. And, AI champions is something we talk about a lot at various institutions. Not everyone is interested, of course, because they have other areas of research or clinical interest. And to be the AI champion at your institution, learning about it however you can and just getting involved, like you said, is a great point for many of us in many different places. Dr. Goldberg, what do you think about it? Like, what do you tell your medical students and residents?
Well, I mean, we hit this one out of the park. You got to go get Dr. Chang's book and read it. I mean, that's the place to start, of course. So, I mean, and it is a great book. But I would say everything Dr. Stewart said is I would say also. I would just add one thing, which is that especially if you're at a medical center, where medical students and lots of times residents are going to be. What I've found is, most major medical centers will have people who are into data science. They may be not doing the exact kind of project that we're thinking of, But, you know, I've always found that people on the non-medical school side still of like, you know, in the math department, whatever, they love getting involved in medical type things, right? There's opportunities for funding, there's more different types of publications like that. So in general, you know, if you don't ask, you know, the answer is always no kind of thing. And so I think that there was a resident who had a particularly like clever idea actually like last year, and you know, COVID messed all it up and everything. But I remember actually thinking, we talked about like, hey, let's go up to there's like a different campus, right, for the undergrad. Let's go talk to some of those programs over there that have. And now in the interim, we've actually landed several new data scientists on the medical school side. But so I think there's a lot of untapped interest there that, you know, we may not even know of, and they might not even know. And so that's why it's important to engage.
Can I just add that
Yes.
on what Ari said earlier? Well, I think most of the clinicians really don't need to spend thousands of hours on programming, because at some point, you know, things are going to be automated to the point where you might regret spending those. I mean, I spent thousands of hours, but because I had to, but in the future, you may not have to. The other thing is, but having said that, I think I agree with Ari that there's a special dual perspective that I think some of us should have. And I think he can probably relate to, if you understand enough data science and computational math and you're a clinician, you can kind of piece together some really interesting projects that perhaps if you get a cardiologist and data scientist in the same room, will probably not get. And I draw sorry about the another analogy, but of all the Formula One drivers, I'm a Formula One fan, as you can see, there's been actually one or two who are not just drivers, but also engineers. And they've come up with some really cool innovations. The rare wing that you see in the cars now actually came from an American Formula One driver. Now, he didn't win any races, but he was a Caltech engineer. And he figured out that when he turned the corners, it'd be really nice to have a different drag on the car. So I think it's hard for an engineer who isn't driving Formula One or a Formula One driver without a full engineering background to come up with those solutions. So I do want to encourage 5, 10, 15% of us really kind of go, you know, in depth understanding data science, and then be sort of the people that can go between the two areas.
Yeah, that's a really interesting point, just kind of being that bridge, you know, in that space. And, you know, there are informatics fellowships out there as well for the residents or medical students that might be thinking about that route, you know, available to them. I don't know what advice we would want to give to those, though, who are past their training. You know, Dr. Chang, you know, with AI Med and the course, if you could talk about that for, you know, those who are tuned in, just to know that there's other opportunities for AI education and just the AI Med ecosystem, which is great, you know, for anyone who's out in practice.
Yeah, I think the AVIM course is pretty good for 2 days of investment and time, and I think you pick up quite a bit. There's also a nice course out of Stanford with my friend Matt Lundgren and their course in AI and health. So I think between those two courses, you should have a pretty good start, at least better than what was available 5 years ago when neither existed. And then you can kind of take it, I always say it's a journey, right? But I do agree with Jessica, jump in. The most important thing is jump in and not be so intimidated that you can't program. And I think that's perhaps the #1 misconception, that you know, clinicians who don't program feel like they're left out. As a matter of fact, you could be the center of a lot of, you could be the epicenter by just being an advocate to get to know this resource. And I know people who were very junior. As a matter of fact, one of my past residents went up to a big institution, and she was the first person to start an AI sort of movement at her hospital in Boston, of all places. So one person can, right now, it's an exciting time. One person can actually do that and make a difference. And remember, she had no AI background. She just wanted everyone to sort of get together and convene and learn about this. And now she's in a great place with MIT right in her backyard, but you don't have to have an MIT in your backyard to get interested and get people to kind of teach each other. We teach each other all the time.
Yeah, I mean, I think that's an interesting point, especially just in medicine in general. Imposter syndrome just is in an epidemic, right? People just can't get enough in terms of degrees and certifications and, you know, specializing things. And you think about, you know, we have someone at the company I'm working with right now who's going to go get a PhD in machine learning. And there's a lot of physicians that just completely forget that they have an MD altogether and just think that now, all right, you know, I'm going to learn about AI. And I feel like I need to do all of these things to the point where we're talking about, like Dr. Stewart, they can't, like she's saying they should just jump in, but they can't even do it because they're just overwhelmed by all the potential resources. And I really want to emphasize to all our attendees that, you know, no matter where you are, you can be that AI champion. You know, you can get started right after, you're right now starting because you're on this webinar listening, but you can get started today. You know, the resources are out there to just kind of decide where you want to go. And I think another thing that comes up is people's learning styles. Whether you learn best from reading a book or if you learn best from watching a YouTube video, or, you know, whatever your method is, if you need to take notes or if you're more of an audiovisual learner, you know, that's something that's come up a lot too, because a lot of our residents and med students don't have textbooks anymore that they're carrying around, and everything is online. So I think a big part of it and advice that I give my mentees is just to think about the best way that you like to learn, because if it's in a method that you enjoy, then you're more likely to kind of stick to it and learn more and more about it. So what do you all think, and this is a bigger, broader question, you know, the future of medicine with AI is going to be, you know, not only for patients, but also for us as we're in the midst of practicing. Dr. Goldberg, what are your thoughts on that?
Well, you know, and this actually dovetails in a little bit with the point we were just talking about in terms of getting people involved and education. You know, I think that it's very important to keep in mind that I think when sometimes we have a tendency, and people have a tendency when they see AI, they're like, oh, it's big things. It's like it's the AI reading the images, interpreting, you know, telling the heart surgeon exactly. Yeah, but there's lots of this AI solutions exist along the whole spectrum of different workflows, right? And so some of them can be very simple, but still very powerful. And so that actually, to answer your question, I think, the best answer is I don't know, right? You know what I mean? I think we all know that AI is going to play a big role, but I think the most important thing to keep in mind is that there's a lot of great AI solutions out there that I think are going to come to, that are going to kind of manifest in the not too distant future, which don't necessarily do the big sexy thing, but they do things that are very important, you know, for radiology work. Obviously I see things through the prism of radiology. So I think, honestly, and I think that'll probably be the nearer term, right? And we see some of those products out there already, but I think some of those things are, you know, they're not as sexy as the getting in this whole report from the AI that says, you know, this is the interpretation of the CAT scan, right? I think that's still a ways away for a lot of reasons, but what's not so far away is some of these workflow solutions that are still very important and very powerful.
Yeah, I mean, a lot of those solutions involve just NLP and, you know, analysis of our patient records for various reasons. I know at the beginning of the COVID-19 pandemic in New York, they were using some of that to look at patient risk factors, demographics for who might be affected by COVID and, you know, and have a worse outcome. And like you said, it's something that at its core is actually just searching text and trying to divide, you know, into categories and do some predictive analytics. And it's not, you know, something like image analysis that we're more used to seeing in radiology. Dr. Stewart, what are your thoughts from the lens of someone doing procedures where, you know, we're talking about maybe AI might be more helpful for triage because obviously it's not going to do your procedure for you.
Yeah, I mean, no, I mean, I view this as we're going to be able to help determine which patients are really going to benefit from which procedures, and predictive factors, you know, maybe that we wouldn't recognize just from, you know, briefly reviewing the chart. You know, I think this is going to be really informative about who we can help best and how to, you know, there's limited resources, obviously, for increasing volumes. You know, we need to be smart about how we work, and also making our procedures more efficient and effective, hopefully. So yeah, I mean, I think, you know, just overall, I think AI is going to help us work smarter, and kind of, you know, use our resources in the best way we can for our patients. And I think it's going to be an incredible tool moving forward.
Yeah, what are your thoughts, Dr. Chang? I really like the point that you brought up that maybe in the, you know, in the hopefully the near future, it'll be more a question of why wouldn't you use AI, in your patient care?
Yeah. I think by the end of the decade, we'll get there. And also, we won't be talking about AI as a separate resource or a separate discipline as much like we are now. So it'll be just slowly. One last analogy, I promise. Okay, it's kind of like I'm actually getting slides ready for a talk tonight, and I think AI, it's kind of like a tsunami. If you haven't seen a tsunami, you imagine it's this big giant tidal wave you see in the movies, but it's rarely that big. It's just a very fast rising water that is slowly engulfing everything. It's a much different sort of perception. It's not this giant tidal wave, which I think a lot of people are thinking, 1, 2, 3 years from now, it's just going to engulf medicine, but it's already here. It's here in a lot of places and in very significant ways, and it's moving fast. So I think, thanks to our radiology colleagues, and cardiology has definitely caught on very quickly in the last 6 to 12 months. All of a sudden, meetings are happening frequently now, and papers are coming out, very fast. So it's like every subspecialty that follows radiology and pathology enjoys a slipstream behind that subspecialty and figure out how to do it faster and quicker and with better adoption. So I think that's going to continue to happen in the next few years. And at some point, just like you don't call your Amazon picks as machine learning, but that's what it is. You just know that it gets done, relatively quickly and efficiently. So I think that's going to happen in medicine. And as Ari said, there's so many low-hanging fruits that we haven't even really begun to take advantage of AI as a resource. I mean, I just came from my cardiology clinic, almost was late for this meeting, but there's so many things that you look around and say, people are still doing that. I mean, one of the nice things about learning about AI is that you kind of just understand that so many things are antiquated in medicine, and that it doesn't even take AI to improve a lot of the processes that computers can just take over and not replace the humans, but just not have your attrition be replaced by humans, let's say.
Yeah, I mean, it's true. There's some antiquated technology. I was telling a friend who works in AI that we still have fax machines in the hospital, and they didn't believe me. They really truly thought I was joking. And I was like, no, that's how we sometimes get patient records. It has to come through a fax, and they don't know how to use a fax machine. And in radiology, obviously some of the patients have their images on a CD, and none of us have a CD drive right now, I'm sure, on the laptop or desktop that we're using for this webinar. Things that doesn't really need AI, I think, right? The fax machine or the CDs. So I mean, yeah, I think sometimes it's a little antiquated and trying to just get up to speed with some basic technology in the healthcare space. But we wanted to end around 4:45 or 1:45. So I just wanted to get everyone's final thoughts on, where you see your AI journey going. And really, most importantly, I think what advice you would give to those who are listening, as they're starting their journey. Dr. Goldberg?
I mean, I would say in the next few years, I hope to just, continue, being part of teams that develop, solutions, like I said, sort of along the spectrum. Some are workflow related, some are image interpretation related. That's just what interests me. And I would say to people who are interested in getting involved, and a lot of what we said here to reiterate is I think it's start from what you're interested in. If you have an interest in some kind of a solution to some kind of a problem, and it's in medicine or whatever, and it has a potential AI solution, go see what the literature says, go see around you who's working on it, and usually good things happen from that.
Dr. Stewart?
Yeah, so I'm going to continue learning by evaluating new technologies for implementation here. And personally, I have a big interest in global health. I've been teaching in Kenya for several years now. So my ultimate goal would be to start partnering up with AI companies or looking at solutions that can be implemented in resource limited settings and kind of bridging those gaps.
Dr. Chang?
Well, not intentionally being a little bit controversial, but I think we ought to start asking, is it ethical not to, use the data that's available in your hospital for your patient care? For instance, this came up yesterday. We had a complicated patient, and I said, why can't we just give doctors access to all the data in the hospital so we can learn from the 35 patients with this diagnosis without a big struggle, And people are saying, well, what about HIPAA? The traditional excuses not to do it. And I just said, is it ethical not to do this? And then it was like silence. So I think people are realizing that, we need to think a little bit more differently about this resource. And there are definitely cases that I think it's starting to feel unethical not to utilize this resource.
Yeah, I mean, that's an excellent point, because that's just within your hospital. Looking at how we could learn from patients who have similar complexity. Yeah, that is important for sure. There is a lot to learn, and sometimes it's not something that we need a YouTube video about or look up an article about, but it's like right in front of us at the hospital.
Yeah, I mean, we're all clinicians. How would you feel if you have a certain rare disease and your doctors are telling you that they don't have access to the data and records of perhaps 5 different hospitals in the region where they have patients with this disease? I mean, you would fight for it, right? You would say, we need to find out what's going on with them. And lots of these cases, as you know, are not published. So we need to really, really fight, not just for our patients, but for ourselves, because we're all going to be patients someday. And hopefully not in a situation where you're going to be really hurt by not having all that information and knowledge available.
Yeah, absolutely. I think we did have one question come in from the audience about how AI can help or contribute for radiotherapy treatment.
That's been really big recently, right, Sonia? Yeah, reducing dosage and having better locations. So that's actually a great way to use AI.
Yeah, or maybe, like we were talking about, just gathering information about patients who need treatment and who might have better outcomes with different types of treatment.
I mean, I imagine they could do some with image fusion and things like that too, to kind of like pinpoint where they would be focusing. Whereas, for example, even recently in interventional radiology, we were still placing fiducial markers to help with targeting these therapies. So maybe they could get away with that with using various landmarks with image fusion.
Yeah, that's a great idea. Yeah. Well, thank you all for your time. Thank you to all of our attendees. This has also been recorded and will be available on the AI Med website. And, we are going to be doing more courses through the ABAIM. For those who are interested, I'll put in a plug for it. I'm part of the faculty and I really enjoy it because there are, it's 2 days. So like Dr. Chang mentioned, we're not going to do 10,000 hours of learning how to code. We have to make it practical and interesting, and with a flipped classroom kind of technique, just keeping everyone engaged is really important. And I think that's been a really great experience.
Jessica and Ari be part of our rotating. We have guest faculty that come through every month. I think this month is going to be Matt Lundgren. He's going to, and it's kind of enjoyable because you're going to learn with the other faculty as well, and make it really. The key thing is we have to make it fun. It's not just like statistics for the last 2 decades. Is sometimes for some people not the most interesting topic, but if we make it really relevant and that it clinically could be impactful, I think we'll get people motivated to learn more.
Absolutely. Well, thank you all for your time, and thank you to everyone who tuned in. Have a good afternoon and a good weekend.